Well, I would ask you first about your height, your weight, whether that weight is stable, at what stage you are in your life in terms of have you had family, are you planning to have family, what are your motivations for wanting to have a breast augmentation? Because people have different motivations. It might be because it's something to do with their job, it might be because they just want to feel better about themselves, and the vast majority of my patient population feel that they would like to fit the clothes that they can buy off the shelf more easily. So they'd like to have a bit more breast shape, a bit more definition between their sort of upper body and their lower body. And once we've established that, find out what bra shape and size the patient wears currently, what they do to try and plump things up, so to speak, and then after that find out about any histories of breast cancer within the family, and then we'll look at other surgeries the patient may have and risk factors for any kind of surgery. So I operate on smokers, but given the chance I prefer not to operate on patients who smoke because they have more problems of wound healing. And then once we've discussed that, I actually normally talk about breast augmentation surgery as a procedure, and start by saying, well, actually it's an operation which ladies are generally very happy with, and it's very easy to concentrate on all the negatives about complications and the risk factors and what have you, but I think it's important to get across that this is an operation which people are happy with to start off with. And then I talk about what's involved in the surgery, what they're letting themselves in for, and I think one of the factors which is unnoticed by people or ignored by people is that if someone has a breast augmentation operation, they are condemning themselves to have another operation at some stage during their life, sometimes more than one operation, to replace the implant, to change their breast and skin envelope around the shape of the implant they have. So it won't be a once only operation. And then once we've gone through that discussion, I normally get a chaperone in with me and we'll have a look at the patient and see what they've got, take some measurements and try and firm up some of the plans about the size of the implant, the place of the implant is where I'm going to put it, whether I'm going to place it beneath the patient's skin and breast or whether behind their muscle and skin and breast. And in terms of sizing of the implant, I talk about sizes of implants, but really implants are ordered from a catalogue, just the same as you'd order some clothes from a catalogue, and they're based on sizes of the patient's breast and chest. So when patients say, what size are you going to increase me to, then generally I would say around 2 cup sizes, but that's not an accurate estimation, and people have to sort of be prepared that there's a certain size that their breast can be enlarged to, and they need to have an idea of what they want to achieve with this surgery. And in terms of the different shapes and sizes, currently I talk to patients about a round implant and a teardrop shaped implant or an anatomical shaped implant. All implants have a silicone shell, and the implants that I tend to use are all silicone gel filled. I don't tend to use saline filled implants because it's not been part of my practice for the most part. Saline filled implants I tend to use for an interim reconstruction for a breast patient where I'm expanding their breast shape and skin envelope, and then I'll exchange it for a silicone filled implant. And the disadvantages of a saline filled implant over time is of deflation. And over time they gradually deflate. The other things that people notice about implants are the surface of some implants are textured or roughened, and the texture of other implants are smooth. And in the UK, as opposed to the US particularly, there was some work produced which suggested that textured implants they decreased the rate of something called capsular contracture, which is the bane of plastic surgeons and patients with breast implants lives, because in a small proportion of patients they get a capsule formation around the breast implant or scar. Everyone gets the scar because it's a reaction to the foreign material, but in some people that scar squeezes on the implant within the breast and changes the breast shape and it can be uncomfortable and increase the patient's asymmetry. So in that situation, if we can have anything to try and avoid that happening, then we do. So I tend to use textured implants, and in terms of round or anatomical, I use both. It depends a little bit on what the patients would like. Some patients would like a more rounded upper pole of breast, in which case a rounded implant is going to do that, particularly placed into a pocket beneath their breast tissue. Some patients want a teardrop implant, and if I'm being guided or guiding the patient through which is going to be as best for them, if the patient's very slim and has minimal breast shape themselves, I think a teardrop shaped implant is better. I think if the patient has a nice breast shape to start off with, I really don't think it matters what shape of implant is used. So I use both. Okay. Firstly, I'd be talking about stopping smoking if that was feasible from the patient's point of view. Then we would organise a date for the patient to be admitted, and in my local hospital the patient would then be pre-assessed in a nursing pre-assessment process, and it depends a little bit on the patient's age and general fitness. So if most patients undergoing breast enlargement surgery are fit, healthy, and so they will get a skin swab to try and diagnose the presence or absence of them being an MRSA bacteria carrier. And if they are, they need a particular antibiotic on the operating table and some preoperative skin washes and showers. And then other than that, their pre-assessment is a matter of form filling, and they come into the hospital on the day of their surgery, and they'll have come in starved from the night before or for a minimum of 6 hours prior to surgery. I do this kind of surgery under general anaesthetic with the patient asleep, and then I'll meet the patient on the day of their surgery. We'll go through things once again. I'll take some preoperative photographs. We'll go through the consent process once again. I'll draw on the patient, and then the patient gets to meet the anaesthetist, who's really the most important person on that day, because they're going to make the procedure safe for them. And then after that, I'll say hello to the patient before she goes off to sleep, and again when she wakes up. And then depending on the time of the day when the patient's having their operation, if their operation is going to be in the morning, then potentially they can go home that afternoon. If the patient's going to have their operation in the evening, then they would then generally stay overnight until the following day and go home then. I place the breast implants in through a scar approximately 5 centimetres long at the junction between the breast and the chest wall, what we call the inframammary fold, or in fact just in front of it. The idea being with that is if someone's wearing a bikini and the bikini rides up a little bit, the scar's not completely on show. And via that route I can make a pocket either in front of the breast muscle or behind the breast muscle. When I started off in the US back in the 1990s, at that stage, late 1980s at that stage, the surgeon I worked with put all the breast implants in through the axilla, through the armpit. And the idea behind that is that the scar is still 4 centimetres or so long, but it's hidden in the armpit, which is excellent. I've tended not to do that because the armpit in most people is dark and moist and a harbinger of skin bugs, and one of the risk factors to breast capsule formation, which we've talked about already, is infection, and so I try not to have any more risk factors for it than I need. Two other routes which people talk about are, one is going through a scar around the nipple areola area or at the junction there. I use that for some patients, but again I find sometimes the scars are more noticeable there than underneath. And then the idea that you have a scar at the tummy button and dissect a pocket up and put an implant in via that sounds attractive, but it means that you have to have a saline-filled implant to start off with, and I generally don't use saline-filled implants. And also, again, for an operation which is relatively simple and straightforward, why increase the complexity of having a greater distance to have to operate through? So I don't use the tummy button approach. Well, post-operatively, you should wake up reasonably comfortably, okay? Because I use local anaesthetic in and around the pocket that we've made. Some patients experience more discomfort than others. Some people are absolutely pain-free, and others feel that they've got a pressure on their chest and it feels tight. That passes off usually over the first 48 hours or so, and the patients, when they go home on simple painkillers such as paracetamol and non-steroidal anti-inflammatory drugs such as Brufen. And I'd expect them to be able to wear a supportive elastic bra and really get back to their normal day-to-day activities fairly soon. I don't want them going and doing highly aerobic activities, but going out for dinner or sort of having some time to themselves is fine. I would suggest normally that patients are off work for up to 2 weeks, but again, it depends on the kind of work that they do. And I would normally see the patients at a week post-operatively, and I use a minimum of dressings. I use some super glue on the wound, and I use a little sort of paper strip called a Stereostrip, so the patients don't have lots of dressings and they can go in the shower straight away, which is one of their main concerns after surgery, is to be able to wash hair and get back to normal that way. Broadly speaking, with any surgery operation, we can divide risks into general risks of a general anaesthetic and the anaesthetic process, and then specific to specific to the particular operation or generally about any operation. So a cut is being made, so patients can have a bleeding problem if they have a bleeding vessel in the pocket which has been dissected. They can develop what's called a hematoma, which is a collection of blood, and that's a nuisance because the patient then has to go back to the operating theatre to have it all washed out and restitched, and it delays them going home. Other things which are consequences of breast augmentation surgery are related to a change in sensation of the nipple and areola. Sometimes ladies can get stretch marks. Asymmetry is something which we always mention preoperatively, because if someone's asymmetrical preoperatively, they're likely to be asymmetrical postoperatively, and often ladies haven't even realised that they have some breast asymmetry, so it's a case of trying to point that out right from the word go. Infection is a real problem. If a breast implant becomes infected, then it needs to come out. And if it comes out, it generally in my hands would need to stay out for about 2 or 3 months, so that's a disaster for the patient. They then can have the implant placed back in, but it is a disaster, and for something which they're choosing to do, we try and decrease the risks of that with good technique, use of antibiotics, etc. And then the other consequence of having this operation is having a scar, and in some people the scars can be pink or lumpy and take a little bit longer to settle down, but generally in my experience the scar from a breast enhancement operation is good. They heal very well.